Hey, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight's topic, eyelid and conjunctival degenerations and growths from benign to terrifying. And we have the great pleasure and fortune, a good fortune, to have Dr. Pierce Kenworthy as our speaker. He completed his undergraduate degree from Brigham Young University and earned his doctorate of optometry at the Arizona College of Optometry. He completed a family practice residency at the University of Houston's College of Optometry, and then he worked privately in practice in the Houston Medical Center. He is now an associate professor at the Arizona College of Optometry, where he's been since 2017. We've had the opportunity to work with him a number of times. The great presenter, great mind, great educator. And I certainly think the students at the Arizona College of Optometry are in very good hands, as we're all going to find out. So with that, Pierce, please take over.
Great. Thank you very much, Joe, for the introduction. And thank you, Greg, also for the invitation to join here tonight. I am thrilled to talk about eyelids and conjunctival degenerations and growths. We had a poll before we started. Several have already diagnosed malignant eyelid or conjunctival lesions, and some of you haven't, and in the last 12 months, but we're going to take a look at a wide variety of lesions in this lecture. So, no disclosures right now. I want to start by talking about the eyelid viral infections. This is a place I think we're comfortable. We see things like herpetic infections and other viral entities, and that's where we'll begin. So herpes simplex, a fairly common infection around the eyelids. This blepharitis is going to appear initially as vesicles on this raised, edematous, kind of reddened and infected looking skin around the eyelid very commonly. That's the first week, but then as the 2 to 3 weeks go by, the lesions start to pustulate. They get filled with pus, and then they crust. And fortunately, with herpes simplex, we don't see scar tissue after the healing of simplex in most cases. Herpes zoster looks very similar to herpes simplex, where within the first 24 hours, we see that macular rash. It usually has a vesicular appearance with clear fluid inside of those lesions. That goes on for about 4 days, then the lesions pustulate and finally rupture and hemorrhage. And we know that our patients are healing when those rashes start to crust over, like we see in the final images here on the right side. Images like this are good examples. A 32-year-old came to our clinic. He was seen at urgent care 5 days ago, and we know was diagnosed with herpes zoster. A very typical prescription for these patients is Valtrex, 1 gram 3 times a day for 7 days. And what I like about his example is right around the eyebrow, we see much newer vesicular type lesions, and then closer to the hairline, some of the older crusty type lesions, showing that change as it started more likely up where the hair was and worked its way down towards the eyebrow. It's not uncommon, but well, more uncommon, but sometimes younger patients, 17 years old. This patient was immunosuppressed and on corticosteroid therapy and popped up with a zoster infection, respecting that dermatome, just half of the face. There was no involvement of the actual cornea, but a lot of involvement of the skin around that eye. And another example of a 55-year-old with a skin rash, and it's a good reminder that sometimes this zoster infection can actually penetrate and pass into the sclera. This patient later developed scleritis as a result of this zoster infection. So, interesting example. And as we continue with viruses, we have to remember molluscum contagiosum. In other words, soft contagious spots. With molluscum contagiosum, it's also a viral entity, very common in our young children, even healthy children or young adults. It can spread quite easily, skin-to-skin contact, scratching, even in swimming pools, which here in Arizona, we have a lot of swimming pools, but they do not get rid of all viral particles. This is actually caused by pox virus. And since we got rid of smallpox, now molluscum contagiosum has the not very honorable designation as being the principal pox virus cause of human disease. And I had a student a few years ago. She sent me this picture. That was her first day of first grade. And apparently her mom thought it was the right time before first grade started to get her molluscum contagiosum removed. So that's her picture on her first day of first grade. That's her now. She's doing great. She came to optometry school. She actually met one of the dental students. They got married, and now he has molluscum contagiosum. That would be funny if that really happened, but we know that it can spread. The fourth virus to mention is Verruca vulgaris, the common wart. We're going to see this on the skin, on the hands, on the face. We're primarily interested around the eyelids, of course, and this is caused by human papillomavirus. Verruca is a wart. Vulgaris is common. This is the common wart that we will very likely see in our careers, probably weekly. If not weekly, then at least monthly. And as was mentioned, it's secondary to HPV infection. And it's worth noting, it has a low risk of malignancy, but that still means it has a risk of malignancy. So we want to watch these in case it's going to be a problem. And the flat ones like Plano, Texas are going to be called Verruca plana. The more digit-like, finger-like ones, we would call it Verruca digitata, and that's Verruca vulgaris. Had a patient from Mexico. He was visiting Arizona, had an eye exam. I noticed this on his eyelid. He said, oh yeah, it's been there for 10 years. And I was surprised when I was asking him about it. He said, oh, sí, Verruca, siempre se dice en Mexico. Yeah, Verruca, we always say that. It's just where I come from. Everybody has Verruca. And it's funny to me because I don't normally go around calling this Verruca. I say, it's a skin tag, not really sure, but they just went right forward and said Verruca. A 45-year-old was getting her eyebrows trimmed 3 weeks ago, noticed this little growth on her skin, and the textbooks now are including that there can be transmission of HPV and have noted that eyebrow and facial hair threading is now a published risk factor for Verruca transmission. So be careful where you do your threading. And for those of you watching, if you don't know threading, here's a fun video of people trying threading for the first time.
The middle, like where the area she's doing now, is actually not painful at all.
Oh, wow. I suppose.
So we know who tolerated that a little bit better. Here it is in slow motion. I can imagine the HPV viral particles just spreading along that string and infecting the patient and causing this right here. So HPV, Verruca vulgaris, our other viral entity. Now we move away from the viruses and get into other benign tumors of the epidermis, including these 6. There's others, but I'll focus on these as they're the most common that we'll see in eye care. Acrocordon, we sometimes generically refer to as a skin tag. And that's okay if we call it a skin tag or a papilloma, but if we do, I think it's important to remember that papilloma or papillomata or skin tag really is not diagnostic. It's just descriptive for a whole range of things that can be skin tags or papillomas. Specifically, acrocordon is this benign eyelid tumor, and to get that specific diagnosis, I suppose a biopsy would be necessary. So in the absence of a biopsy, we usually just say it's a skin tag. But these acrocordon can have a whole variable appearance, flesh-colored lesions hanging off by a little pedicle, a pedunculated type, maybe a flat sessile type. This is what we see in our patient, 73 years old, had this for a long time on his right lid and his left upper lid and wants them removed. And you can see sometimes they even have a little reddish appearance to it, and there it's just hanging right off the eyelid, just waiting to be removed. 64-year-old patient has had these for a long time. You see at the beginning, that central one is a little more sessile, kind of a flattened type of acrocordon. That other one, it looks like you just want to hang on like Tarzan, or even more important, maybe grab your scissors if you're in a state that can do this and actually snip that off. I'm in Arizona, we can't do that, so we refer these out if patients want it removed, but fun to see how optometry is changing and allowing for more of that to happen. Another benign entity is epidermal inclusion cysts. These are fairly common and kind of fun to think about how an epidermal cell can get implanted deeper into the dermis, usually by a result of trauma or surgery, and they just slowly grow and proliferate beneath that surface of the epidermis. And something that I'd never want to eat for breakfast is a cheesy keratin-filled epidermal inclusion cyst, but that's how we describe it, just this kind of a hardened keratin-type filling inside of these cysts. Most of the time, they don't really cause much of a problem. However, this 66-year-old patient, she's a contact lens wearer, and said, yeah, when I'm putting my contact in my eye, I put my finger on my skin and kind of pull my eyelid, and I feel it. It kind of bothers me. And at first glance, when we look at this, we might think that it's part of the nasolacrimal drainage system causing a problem, but this is more superficial. And sure enough, this biopsy came back as epidermal inclusion cyst. And I like how the pathologist included a very descriptive term. They said it contains white tan grumous tissue. And grum is a word that indicates something that once was liquid and became more solid, kind of like blood that coagulates. And some have suggested that this begins as a sebaceous cyst, oily secretion that sits long enough and becomes more hardened, like the grumous tissue that this pathologist is reporting on. Another benign is seborrheic keratosis, very common. We're going to see these very commonly, in especially our older patients. A brown, usually stuck-on lesion. There's another term for this, basal cell papilloma. I was talking to a dermatologist. He said, oh no, we never use that term. Just call it seborrheic keratosis. And I think they don't use it because that's so close to the carcinomas, which we'll discuss later. So seborrheic keratosis on the face can be these smooth, kind of greasy, elevated lesions. Just looks like it got stuck on, like somebody flicked it on and it just stuck on the face right around anywhere on the face, around the eyes. Specifically, eyelid lesions that we're going to see at our slit lamp when we're doing our slit lamp microscopy have a whole wide range of descriptions. Many make me chuckle. They could be lobulated, papillary, or pedunculated, or friable with kind of a flaky surface. And my all-time favorite is cerebriform. Now, seborrheic keratosis can look like a little brain growing on our eyelids. So it can be a whole variety of appearances. And then there's this patient that comes in. And I stare at that for a while and I think, well, boy, I already learned a lot of things that could look like. It could look like acrocordyon. Maybe I'll just call it a skin tag. It got sent off for biopsy, and that actually was seborrheic keratosis. So even though in the last view we saw a lot of these being pigmented, they don't have to be pigmented. Here's a 75-year-old says this has been there for several years on her right lower lid. She wants that removed. Question is, what is it? Maybe we don't know. At least we can know, are we concerned about malignancy or not? It doesn't look like a malignancy, but she wants it removed. This is the lidocaine injection just for numbing around the base of that lesion, just to make the patient more comfortable for the actual snipping and cutting of that lesion away from the skin. The next step is going to include the actual cutting, where you have jeweler's forceps grasping that lesion, and as close to the base as you can get is the snipping to completely resect that from the tissue beneath. And this is a very small wound area, heals very quickly, and that patient now is free of this lid lesion. This particular patient did not bleed very much, but for any bleeding, cautery can be used. So this very fine-tipped cautery unit can just shut down that bleeding as a little hemostatic type of agent. And finally, even though we knew this was very likely benign, that tissue was sent off in a little sample to the pathologist, and it came back as, you may have guessed, seborrheic keratosis, but had features of verruca, so maybe a little HPV in there as well. Another benign entity which deserves just one slide, but I'll give it to you, is milia, named after the millet seeds. And we actually have one of our 6 kids' names is Amelia. So what do optometrists do? We name our kids after eye diseases. So this is milia, these small raised white little superficial cystic lesions with hard keratin inside. It's fairly common in newborn infants and comes in crops, which also is suggestive of those millet seeds. If it's bothersome to the patient, they can be removed one by one. And actinic keratosis is still in the benign, but now we get a little worried because this can lead to malignancy. And especially here in Arizona, I'm very mindful of the sun. It's 110 degrees. We also call this solar keratosis. These are proliferations of transformed keratinocytes. Keratinocytes are epidermal cells that produce keratin, and anytime I see the word transformed, I get nervous. That means that cell is no longer behaving the way it's supposed to behave. And this is induced by sun exposure, and we're going to see it on parts of our skin that are exposed to the sun, back of the hands, top of the ears. If you're the type to stand while you're doing your refractions, you might see it on the bald head of your patients. And the concern is that this has a low risk of conversion to squamous cell carcinoma. It's very small, less than 0.24%, but the more AKs a patient has, the longer they have it for, the higher the risk of conversion to squamous cell carcinoma. So be mindful of these precancerous lesions. And dermoid cyst takes us in a new interesting direction. Dermoids fall into a category of lesions called chorostomas. A chorostoma is a tumor-like growth composed of very normal elements, normal cellular structures, but it's in the wrong place. And I think of a polar bear. It is an absolutely normal creature. We would expect to see a polar bear walking in the Arctic. If we see it in the jungle, we might get a little surprised by that. The same with a dermoid. It's normal tissue, but it's in the wrong place. So dermoids are core stomatous congenital lesions normally present at birth. Very commonly, if we're looking at the eyelids or the conjunctiva, they'll be inferior temporal limbal region. And small ones just look a little tan. Very large ones might get much whiter and start to affect the cosmesis for the patient. And this is fairly tough tissue. It comes from the outer third of the sclera and has a lot of normal things, but again, it's in the wrong place. Like it has hair follicles, sometimes hairs grow out of it, sebaceous glands, sweat glands, or even fat lobules growing out of these. And dermoids have some associations with systemic conditions. One of those is Goldenhar syndrome. Patients with Goldenhar syndrome have preauricular appendages, these little growths at the front of their ears, or even hemifacial microsomia. Half the face is poorly formed and smaller. Or a whole collection of mandibulofacial dysautosis like Treacher-Collins syndrome could also be associated with dermoid cysts. As far as management goes, these can grow as the patient is growing. The good news is most of the time they do not undergo neoplastic transformation. So we're not worried about malignancy. We're more worried about things like inducing astigmatism, causing amblyopia, the patient being irritated, or most likely the cosmetic deformity and the problems with people perceiving them and how they feel about themselves. So that's when those need to be removed in most cases. This is a young patient, 11 years old, showed up to our clinic. In his case, he wanted it removed for cosmetic reasons. Said the kids at school kept looking at him, asking him, "What in the world is that on your eye?" And he did have it removed. This patient also had Goldenhar syndrome, so we saw that association with him. More recently, had a 17-year-old. Her parents said that she was born with a dermoid, a limbal dermoid at birth. It was present there, but they've noticed it's just been growing more and more towards the center of the eye. And the challenge now with this patient, she's 17 years old, and her refractive error, she's a plus 5.75 with 7.5 diopters of cylinder, best corrected 2300. We even put a scleral contact lens on her eye. This video is just showing you what it looks like at the slit lamp again with a transilluminator. And even the scleral did not improve vision. So now we're obviously concerned that she's had amblyopia and not going to get that vision back. This is what the topography for this patient looks like, where you can imagine that dermoid is pressing and flattening the horizontal meridian of this patient's cornea. So it's very steep in the vertical meridian, top to bottom, and very flat horizontal along the axis 180. And that's what we would expect to see with the rule astigmatism, like we found with her. So those are some of the benign lesions, non-vascularized for the most part, but there's some vascular benign tumors that we should be aware of as well. And I think these three make a beautiful picnic. If you're a wine drinker, I'm not, I'm a juice drinker, but nevus flammeus is the port wine stain. You got the strawberry nevus or the strawberry hemangioma, and then the cherry hemangioma. So we'll start with the port wine stain, also known as nevus flammeus. It's fairly rare and it's congenital, usually at birth, and follows a dermatome just on one side of the face. And now this is composed of dilated capillaries. So when we think about actually pressing our finger against this, those capillaries are just abnormal. And it's not like you're going to push the blood out of the way. It's actually abnormal capillaries on the surface of the skin. So whether you press or not, you can't blanch that like you can with the next one we'll talk about in a moment, the capillary hemangioma. And over time, as patients get older, these get darker, and the skin over the surface can actually hypertrophy and get thicker and really coarse. I was reading the news a while back, and this article caught my attention. It was a nursing student born with a massive birthmark, and she's been through 20 surgeries to treat Sturge-Weber syndrome, and I'll mention that in a moment. But I just love her attitude. Horrible people told me I shouldn't come out in public and stay inside, but I didn't listen to them because it's my life. I believe in myself. My face doesn't define me. So a very good attitude from this now nurse, amazing person. But that article mentioning Sturge-Weber syndrome, what is that? If it wasn't bad enough just to have the cosmetic deformity of a port wine stain, now some patients deal with Sturge-Weber syndrome, where they might also have it associated with leptomeningeal angiomatosis. The meninges are surrounding the brain. The leptomeninges are the thin ones, the arachnoid and pia mater. Lepto just means the thin ones. I think a wonderful diet somebody should come out with is the lepto diets, the thin diets, but nobody's come up with that yet. But these patients now can have seizures or hemiparesis, or the eye can be afflicted with more vascular hamartomas like a choroidal hemangioma. And that now we call it Sturge-Weber syndrome. When I was in residency, I was shadowing a retina specialist, and I was surprised when this 4-year-old got referred in. I wondered, what in the world does a retina specialist have to do with this nice 4-year-old with just a little red on his skin? Turns out he failed his vision screening at his pediatrician's office, and his left eye is light perception. He has an APD in that eye, and he's got a port wine stain. And the reason why he was seeing a retina specialist is because he had a huge choroidal hemangioma that caused an exudative retinal detachment. So now we see something that might look fairly simplistic, but actually causes big problems. And especially when we see it at that V1 ophthalmic branch of trigeminal, those become a little more concerning. Another patient I met down in Mexico, I was on a Vosh trip and we were doing eye exams, giving out donated glasses, having a great time. And this beautiful, intelligent, wonderful young lady came. And I've always been saddened by how she said she was treated, how people looked at her. And not only that, the fact that she's lost her vision in that eye. The challenge with this patient, as you'll note in this picture, is she's got those enlarged episcleral veins. And we remember as aqueous is in the anterior chamber, it tries to escape by going through trabecular meshwork. Most of it goes into Schlemm's canal and finally has to go out through the episcleral veins. But with Sturge-Weber syndrome and port wine stains, we see this backup of that blood and these hamartomas that make it so the aqueous can't get out. So now she's dealing with a blind eye, very likely with glaucoma and optic nerve dysfunction. And pupils, you can see as you swing to the right eye in your APD swinging flashlight test, pupil dilates up, left eye constricts back down, right eye back dilated. So she has an APD and loss of vision. So those port wine stains really can be troublesome, not only for cosmetics, but also for other impact on the vision. And the second part of our picnic is the strawberry, the capillary hemangioma, perhaps less sinister, but still can cause a lot of cosmetic deformities. This is the most common, and anytime I see most common, I think we will see this, most common benign periorbital tumor of childhood. It's a vascular hamartoma. This one's a little different. You put your finger on this and you might actually see the blood spread away and out of the way a little bit. And most of these are not present at birth, but show up by about 2 to 6 weeks of life. And I have 6 kids. I guess the chances were high that at least one of my 6 kids was going to have this. And sure enough, one of mine did behind her ear, and I'll show you her pictures in just a moment. And 95% of these are evident by 6 months of age. And now beta blockers. Particularly systemic propranolol or other topical beta blockers are being used with some success with the strawberry hemangioma. This is my daughter. This is Amelia. She had a little one behind her ear, but it was growing quite rapidly. And her favorite part of mealtime was getting her little oral propranolol. It was actually hemangiol, a flavored syrup. If any of you have kids, you know it's maddening to get a disgusting tasting thing in their mouth. So if you flavor it with, actually this was strawberry flavored, then they'll take it much more readily. But this is her after a year of taking that. And you can see, again, not large, but this was in a cosmetic area where a young lady would probably want to wear earrings. So we consulted with a dermatologist and did have her on propranolol. And now she's off of it and looking much more like this. And there are some different birthmarks that can occur at the time that a child is born. We sometimes hear about an angel's kiss or a stork bite. Angel's kiss being on the glabella or eyelid, stork bite at the back of the neck. But these are just nevus simplex, a different entity not to be confused with capillary hemangioma. And one more third part, and if you'll indulge me, I'll call this one the cherry on top of our picnic. This is the cherry hemangioma. It's just the same thing as the strawberry hemangioma, except it's acquired in older patients. You might see 1, you might see up to 5, you might see more. They might be 1 millimeter, 5 millimeters in size. Don't normally cause a problem, and most patients don't even know they have it. And they might look like a real bright red, might even look like a deeper blue, depending on the depth of the skin that they're in. Brighter red being more superficial, deeper blue being deeper in the tissue. So let me see, based on what we've talked about, a few different things. Polling question number 1. And I know that Greg is behind the scenes polling this up, but I'll read the question to you. Which class of drugs can be used for treatment of the pictured condition? Is it A, alpha agonist, B, beta blockers, C, carbonic anhydrase inhibitor, or D, antihypertensives?
The polling question is open. You are correct. People are responding.
Great.
Pierce, I have a question. Whenever I was taking my Oklahoma license and I took the surgical course, and you mentioned, most of these, were benign. And one of the tips or tricks that was mentioned, I just kind of want to get your thoughts on it, is if it's kind of growing outward, since cancer has like enzymes, like most of the time, these benign lesions don't have those enzymes, so they have to grow out, like your viral infections, so on and so forth. So you cannot always say never, and always, never say never, never say always in medicine. But is it a good, okay rule of thumb to say, if it's not eating away and it's growing out, that it kind of helps with that kind of benign diagnosis?
Absolutely. I think that's a great rule of thumb. And like you say, never say always, always say never. It could be a variation, but that is a good rule of thumb. We're going to see some of the carcinomas, like the basal cells, which do have a tendency to ulcerate and just destroy that tissue. The one caveat is sometimes squamous cell carcinoma throws us for a loop because it produces horns, cutaneous horns off the surface. And so that would look more like some of those outward projections of tissue, but actually ends up being carcinoma. So yes, as a general rule, I love that thought, but still be cautious if there's other concerning characteristics. But I like that.
All right, so let me give you the results here. We have 7% saying alpha agonist. We got a whelming 85% saying beta blocker, 5% going down to carbonic anhydrase inhibitor, and 3% saying antihypertensive. So 85% is your beta blocker.
Beta blocker for the win, and that's the one that we see being used not only for capillary hemangioma, which is what's pictured here, but also port wine stain in some cases. So good. Thank you. Now we're going to
Joe,
keep.
are there any questions in the chat
There,
box?
there are not. We're good.
Okay, perfect.
Okay.
Thanks.
Well, there's other vascular tumors also. This one, I'll give it the designation as being a benign vascular tumor with the wrong name. It's pyogenic granuloma. And there's at least one person here, maybe, who hates their name. I remember going to high school with a girl. Her name was Heidi. And it wasn't till the end of high school that she admitted to me that wasn't her actual given name when she was born. Her parents called her Megan, but she hated her name so much that she had it legally changed to Heidi. And I think pyogenic granuloma deserves the same treatment because pyogenic means producing pus. This doesn't do that. Granuloma is an organized collection of macrophages. This is not that. So really, this deserves a name treatment change. Some have suggested lobular capillary hemangioma as being a better name for this, but I think we're going to have a hard time changing our vocabulary. So for now, we'll keep calling it a pyogenic granuloma. These grow very quickly and are vascularized, sometimes painful red lesions, and they can be fairly bloody in some cases. And these are secondary to surgery or some other trauma or even infection in the eye. Now, I've got this case. I'm going to pack a lot into this short video, but to give a preface to this patient, he's been dealing with meibomian gland dysfunction for a while. And all of this irritation has led to styes and finally led to a pyogenic granuloma behind his eyelid of his right lower lid. It's going to start with the lidocaine injection to numb behind his eyelid, and that's going to be preparatory to a couple things. First off, we see meibomian gland probing. More was probed than what I show in this video, but it's a very small, short-length needle that's getting inserted into each meibomian gland orifice. It doesn't necessarily need to be specific to pyogenic granuloma. Just anybody with recurrent styes or meibomian gland dysfunction can go through a meibomian gland probing. The expression now shows that very turbid yellowish fluid coming out of the meibomian glands. And the last portion is removing that irritated conjunctival tissue, the actual pyogenic granuloma. And that's just going to be excised similar to the skin lesion that we were looking at before. And then steroid is getting injected similar to what we see with any other styes. Now that's a quick peek at the Elman cautery unit. It's not a cautery, I should call it radio frequency. It's actually not heat. It's radio frequency energy being applied to that lesion to try to control some of the bleeding and also shrink down some of that tissue. So I found that to be an interesting case of pyogenic granuloma resulting from this excessive irritation and meibomian gland dysfunction in that patient. And we'll see it in other cases. I saw it recently in a post-op patient who had a sclera fixated lens implant, and the surgeon had to access their sclera, and it left over just a little pyogenic granuloma right over the conjunctiva further up on their eyeball area. Next entity is a benign tumor derived from histiocytes. Histiocytes are sort of immune-derived cells. So I'll just say this is a very cool name, xanthelasma. It's fairly common. It's usually going to be bilateral in our middle-aged to older patients and is very often associated with hyperlipidemia in especially our young men, our young males with a family history of hyperlipidemia or high cholesterol. And we'll see it right on the inside corners of the eyes, just this yellowish subcutaneous plaques. And I remember a student went into an exam room, They took a look at their patient, came back to report to me about the patient. They said, well, Dr. Kenworthy, I've got a 37-year-old male in there and they have ARCUS. And I thought for a moment, I said, really? ARCUS in a 37-year-old? That's surprising to me to see ARCUS. Are you sure? They said, yeah, I'm certain. And I went in the room, and not only that, they had xanthelasma. And this patient actually said, oh, yeah, I've had hyperlipidemia. My mom had it. My dad had it. I'm dealing with this. I can't figure it out. And that's what we're seeing in their eyelids. It doesn't have to be from high cholesterol. This particular patient, 71 years old, says, no, I do not have high cholesterol. This just popped up pretty suddenly. I have thyroid dysfunction, though, and I'm taking Synthroid. So in this particular case, it was maybe more thyroid related. We also see this with diabetics as well. And all around our face and on our skin around our eyes, we have sweat glands. Primarily, there's eccrine sweat glands and there's apocrine sweat glands. The eccrine sweat glands are independent of the hair follicle and can lead to this entity called serangiomas. An apocrine gland, we sometimes call these just glands of mole. And if these proliferate and fill with fluid, we might call it a cyst of mole, or maybe even better is apocrine hydrocystoma. First, serangioma, I'll give it just a little attention here. These are benign proliferations, just these kind of waxy yellowish nodules that form along the cheek or along the brow area, very common in our young women. Lower eyelids would be the most common to be affected, but it can pop up really a lot of other places on the face as well. And these come from eccrine sweat glands, benign, nothing to worry about. Apocrine hydrocystomas would be the ones that probably would be more challenging and may affect the eyelid depending on the size. These are adenomas of the secretory cells of glands of mole. Most pop up as just a single solitary lesion, though sometimes we can get a whole crop of them along the eyelid. And if you take your transilluminator, in most cases, you can shine your light and it should light up like a light bulb. And that's indicative of the clear sweat fluid inside of it that's coming from the cyst of mole. So apocrine hydrocystomas, it might be what we see with this 66-year-old female, has that growth on her upper eyelid. She's had it for a long time. One more view up close. And I like this view because it actually shows the hair growing through the lining of that apocrine hydrocystoma. And it's a good reminder that this one is associated with the base of the hair follicle. We think that cysts of mole have something to do with lubricating and helping those actual hair follicles and keeping our hairs nice and healthy. And if they proliferate, this is what we might see. And moving on into benign pigmented melanocytic lesions now. We're going to see a lot of different pigmented lesions. And because this is CE, we can't just call it a freckle. We're going to call it an ephilus. And I have a lot of Irish ancestry. I think I'm 85% Irish. One of my daughters has freckles all over her face. And that's something that we're going to see in a lot of our patients. It's worth mentioning only because it's no risk of malignancy. And it's a good anatomical reminder that this melanin being produced is from melanocytes. I like to think of melanocytes as being very active little factories that produce melanin. And most patients, whether they have a lot of pigmentation or not very much pigmentation of their skin, actually normally have about an equal distribution of melanocytes. What's different is how effective those melanocytes are at producing melanin. The more melanin they produce, the more pigmented the skin is. And of course, if we go out in the sun in Arizona, 110 degrees, we're going to see those freckles darken a little bit, which is a reminder of the protective nature of the body. It's producing more melanin to absorb UV light and protect us from skin damage from the UV. So I think that's pretty interesting. But that's a freckle ephilus. We get into a little bit more concerns when we see a congenital nevi. These could be flat papules or nodules, develop over time, might be at birth, might develop a little bit later. And the small ones, we don't worry too much about. The larger they get, we might even call these a giant hairy nevus, which I know is not a very flattering name, but it's also very concerning because now we have an increased risk of melanoma. And another concerning news article I saw was this Florida toddler born with what the parents, I think, affectionately call Batman mask due to a rare skin condition, and she was looking for treatment in Russia. And the article says Luna was born with a congenital melanocytic nevus and has a higher than normal risk for melanoma. And that's the concern when we see these large congenital nevi, not just for the cosmesis, but also the concern for cancer. She did get some treatments actually in Russia, and it's eliminated a lot of that pigmentation, but you can still see a lot of pigments of her upper brow and right below her eye there as well, but definitely making some progress with the cosmesis. And then there's acquired melanocytic nevi or nevocellular nevi. These are named based on their anatomical pathological location, being either junctional, compound, or intradermal, and they can have a whole variation in appearance. So our junctional nevi are just normally in young patients, very flat pigmented macules of the eyelids, and histopathologically, they are found at the epidermal and dermal junction. Then we get into the compound nevus, which is slightly older patients, middle-aged, raised lesions, light tan to dark brown, and these are at the junction and within the dermis. And what I like about this image with the lesion on the upper and lower lid is that is sometimes referred to as a kissing nevus. And at first glance, it feels a little bit like an infectious entity infecting the upper and lower lid. But in reality, it's a reminder of embryology, that before a child is born, when they're developing in the embryo, that child, their eyelids are fused. So these abnormal cells get implanted in what's going to become the upper lid and also the lower lid. The eyelids separate before birth, and now we have something that's affecting both upper and lower lid. And the third is the intradermal nevus. These are all older patients, might have little hairs projecting out of them. And this you'll see within the actual dermis. As far as melanoma risk goes, we get a little more concerned about our younger patients who would have more of the junctional and compound nevi, and if they're larger in size. Our older patients who said, I've never had this before, it just popped up a few years ago, it looks like an intradermal nevus, almost no risk, very rare risk of conversion to melanoma. So we feel much better about those. So when do we get concerned? It's when we are worried about malignant eyelid neoplasms. Some features to be concerned about are very rapid asymmetric growth, ulceration of that skin, the patient's complaining of itching around that skin, they're trying to rub scabs off of their skin, they're painful, the color's changing, and they bleed. Any of these risk factors or these characteristics should very likely need to be biopsied to rule out malignancy. And we had that poll before, how many have seen in the last year an eyelid malignancy or a skin malignancy? If you were one that said no, let's remind ourselves, we will see this. Carcinoma of the skin is the most common malignancy in the United States. Nearly 5 million people are treated for skin cancer. 40 to 50% of Americans who live to age 65 will be diagnosed with at least one skin cancer in their life. And optometrists, all of us, about 5 to 9% show up in the eyelids. So we are very likely, yes, going to see skin cancer if we haven't already. And the most common is basal cell carcinoma, the absolute most common skin cancer, not just of the eyelid, but the whole body. And we, of course, will see in the eyelid about 90% of all eyelid malignancies are basal cell carcinoma. So if you're a gambling person and like to take your chances guessing at things, if you see something that looks like a malignancy on your eyelid, it's very likely basal cell carcinoma. And who gets this? Men more likely than women in their older age. And the risk factors are what you see right here in your webcam with me. Fair skin, I cannot tan for the life of me, and I live in Arizona and have a lot of sun exposure. So for somebody like me, it's not so much a question of will I get basal cell carcinoma, but for me, it's more when will I get it? And that's something I have to, a reality I have to live with and understand I need to see my dermatologist. These grow quite slowly, are locally invasive, so they can spread just locally, but good news, they don't normally spread to the rest of the body. They're not normally metastatic. And what we see is a translucent, kind of white flesh-colored lesion that stretches the skin, and that's what we expect with basal cell carcinoma. Some of the very concerning risk factors around the eyelid is if it starts to destroy meibomian orifices, we lose meibomian glands, or we see matarosis, a loss of our eyelashes. This is much more concerning for malignancy. And this is a good example of a patient who had basal cell carcinoma removed. I like the example because you look across most of our eyelid and eyelashes are intact. I know there's lots of fluorescein mixed in there too, but when you get to the nasal side where the actual basal cell carcinoma was removed, there's of course a divot there as well, right there where we would expect to be missing some meibomian glands, and there's no lashes. Now, you might say, well, maybe it was just the surgery removing the basal cell carcinoma that removed the lashes. Possible, but also if you see a patient who's lost their lashes and has a lid lesion, much more likely to be a carcinoma type problem. And I also like with the infrared meibography, you can actually see those missing meibomian glands right in that location where the basal cell carcinoma was. So certainly something to be mindful of. There's more than just these types of basal cell carcinoma, but these would be the three most common for us as eye doctors to see: the nodular, nodulo-ulcerative, and morphiform. Nodular is the typical shiny, firm, pearly nodule, just growing on the surface of the eyelid, right at the eyelid margin in some cases. Might even have little telangiectatic vessels growing, and normally initially grows very slowly, but given enough time, they can develop an ulcer. And now we get into the nodulo-ulcerative basal cell carcinoma. And what happens here is the lesion is growing so rapidly that the interior, the inside of that tumor, outgrows its blood supply, and it just craters in and caves in and ulcerates on itself. So the borders get rolled up and indurated and hardened, and the inside of it starts to ulcerate. And I remember as a student, I heard this term before, rodent ulcer, and I thought I misheard it. And then I looked it up. Yes, that's truly lesions that resemble tissue being gnawed by a rat. So that's what happens with basal cell carcinomas. The third I'll mention is morphiform or sclerosing basal cell. It's less common, but what can be tricky about this one is that it laterally infiltrates beneath the epidermis. It's kind of hiding from us, just beneath the surface, and becomes kind of a hardened plaque on the surface. And in early cases, we may suspect and say, oh, it's just chronic blepharitis. But it's a good reminder, and I remind myself of this often, if I'm tempted to say or diagnose my patient with unilateral chronic blepharitis, I usually pause for a moment and ask myself, could this be from carcinoma? And I think that's a good question to ask. An example of a 70-year-old patient, he had his exam, everything looked fine, but then this lesion started growing for about 6 months. And one thing I like about this example is these little feeder vessels going right towards this lesion. Now, interestingly, he still seems to have all of his eyelashes intact, but there's enough of a concern here with the feeder vessels and the rapid growth that this was sent off for a biopsy, and it came back as basal cell carcinoma. And this was specifically superficial and nodular types of basal cell carcinoma. Some of those I haven't discussed here, but there's a variety of different types of basal cell carcinoma it can be. So that's great news. It was detected, it was removed, and 3 years later, the patient comes back to see us. And I look at that at first glance, and what bothers me is if I looked at his record and said, oh yeah, he had basal cell, he had it removed, and I look at that eye, at first glance, I might say that's just because he had surgery. That's just because this patient had basal cell carcinoma. But now we see the missing lashes. We see this whitening happening. Patient says this feels a little different. Something's changing. It was sent out again, basal cell carcinoma again, this time nodular and infiltrating types. So we're not always completely out of the woods just because we look at the chart and say they had basal cell, and we look at their eye and say, well, that's abnormal, but it's probably because of the old stuff. That's not always true. It could be basal cell all over again. And that leads to polling question number 2. Think about this patient we just saw. We saw him, was removed, was basal cell, then came back, was basal again. What now for this patient who is diagnosed with recurrent basal cell carcinoma? A, is it an injection of a chemotherapeutic drug? B, topical application of chemotherapeutic drug? C, radiation? Or D, Mohs surgery?
And Pierce, while that polling question is launched and I see people answering it, a couple of people mentioned they didn't see it. So on the right-hand side, chat polls, you should be able to click on that and the polling question should be there. If not, you can do like you were doing before, just put your thoughts in the chat box and we'll see what happens there.
Thanks, Greg.
Joe, any questions in the chat box?
There are not.
Okay, so remember everyone, this synchronous course, if you have any questions, please put those in the chat box. We were talking with Pierce beforehand. He's more than happy to answer those questions. And thanks for answering this polling question and making this the synchronous part, as Joe did so well of explaining.
And as we're waiting on those answers, looking at these chemotherapeutic drugs, I think most of the answers are probably getting in, but one of those is 5-fluorouracil. And I actually had a patient who said, oh yeah, my nurse, she just comes to my house and gives me an ointment with 5-fluorouracil to put on these lesions on my skin. And I thought, does that really work? And sorry if you answered that, but I'll start commenting on that answer choice. That does have some success. About 70 to 80% of patients with that application of 5-fluorouracil is successful. After 5 years, we don't see cancer returning. But Greg, I'm hoping the majority.
We have 15% injection of chemotherapeutic drug. We have topical applications, 7%, 3% radiation, and your winner is 73% Mohs surgery.
Excellent. Mohs surgery, and that's what we want. and 73% said Mohs surgery. The cool thing about Mohs is that it's 95% successful, and I'll talk about that in a moment. This is the patient that got sent to the oculoplastics. Sorry for the black and white, but that's what we got back. It was actually a fairly substantial portion of the eyelid that had to be removed during his Mohs surgery, but now he is much more in the clear. So unfortunately, the chemotherapeutic drops and injections don't work nearly as well as just Mohs surgery. So that's the best available option. If you're worried about,
Here,
oh yeah,
a question just rolled in.
sure.
With these lid margin lesions, do you work with an oculoplastic surgeon or a general dermatologist or even a specialty dermatologist?
Yes, so it's going to have to be for the lid lesions that are diagnosed carcinoma. It's going to be a specialty dermatologist trained in Mohs. And so you could refer directly to them. Depending on that Mohs surgeon's level of comfort, they may not actually feel comfortable with eyelids. Some do, some don't, in which case you may be better off with oculoplastics, who also is trained in Mohs, because you can have oculoplastics trained in Mohs. So I think that's looking around in your area, seeing who's actually capable of doing this surgery and willing to do this surgery. But for us, we have a wonderful ophthalmologist that do basic lid lesions for like shave biopsies. But when it gets into some of the deeper tissue with more reconstruction involved, then you're going to need more of a specialty dermatologist.
Yeah, in our practice, we have as one of the offices an aesthetic practice, and
Yeah.
in it is our dermatologist who is a Mohs surgeon and the oculoplastic surgeon as well. So they're in the same office.
Oh, fantastic. Yeah. And sometimes collaboration between the two needs to happen too. Thank you. Any other questions right now that you had?
The only
No,
comment
we're
I was
good.
going to make is that one where you showed the Mohs, I had recently had a patient that had kind of the same thing where they took off a huge chunk of the eyelid, and she's about a year out right now. And amazing, the reconstruction, using skin, mucus lining from the mouth, recreating. It's almost that you can't even tell. Well, without looking with the microscope, you can tell barely the reconstruction that they did. These guys are amazing. And gals.
Absolutely. It's incredible. Thanks for commenting on that. So Mohs surgery really is what's needed, 95% success. And with Mohs surgery, one of my favorite days I ever actually did was I shadowed a Mohs surgeon during his clinic, and he had, I remember, 3 exam rooms, and in each room he had a patient with some diagnosed carcinoma, a basal cell, squamous cell, basal cell, and he just went from one room to the next, taking off a piece of tissue. He handed the tissue to his tech, who froze it, sliced it into thin sheets, and then loaded it onto a little conveyor belt looking thing. Of course, in this video, it's showing it done by hand, but normally this is automatic with like a bike chain that just passes those slides through different dyes like hematoxylin and eosin. And then the Mohs surgeon can go back at the microscope just within about 15, 20 minutes of that being dyed, and can actually look at it under the microscope and see how much of that carcinoma was removed. Was all of it removed? Do they need to keep digging and cutting? And they keep going until the tumor is completely gone. And it was so fun because he had a double-headed microscope there. And I remember he sat at one side. He said, "Come on, have a seat. Take a look at what I'm looking at." And he said, "Pull out your phone, take a picture to show to your peeps." So I took that picture and I stared at it for a second. I said, "Hey, you got to help me out. I'm not a dermatologist. I'm not a pathologist. What am I looking at?" He said, "Well, look, all this outlined in yellow, that's basal cell carcinoma." And I said, "That is satisfactory for me. That's as much as I'll understand about pathology, I think, right now." So basal cell carcinoma, and it's really an interesting process seeing this happen. And as you mentioned, Greg, with the reconstruction, it is phenomenal what they do. This patient had a really pretty significant amount of their lower lid removed, and that all is graft tissue that we're seeing in that right lower lid. Of course, we're missing eyelashes. We're probably missing a lot of the meibomian glands back behind there, but they don't have carcinoma, and it looks really cosmetically very acceptable. And the neat thing about mucosal tissue, and that's where it becomes, I thought, kind of challenging, because the conjunctival tissue is mucosal tissue. And this patient actually had squamous cell and basal cell carcinoma removed from their left lower lid, replaced with actually skin. This one came from behind the ear, and that was selected because it was very thin tissue. And I thought, well, wait a minute, you're taking non-mucosal tissue from the ear and putting on the conjunctiva, and it actually goes through a process, takes a few weeks of it mucosolizes. So that tissue becomes mucosal tissue. Same thing if you take tissue and put it in the nostrils, if that's where reconstruction is needed, it will mucosalize. So a very neat process. Love it. Squamous cell carcinoma becomes much more concerning because of its aggressive nature. This is the less common One, compared to basal cell carcinoma, but much more aggressive. In fact, it's metastatic in 20% of cases and can even pass through the orbit into the intracranial space. The risk factors are the same, like on the lower lid, our older patients with a lot of sun exposure. Seems to be immunocompromised patients are more susceptible to squamous cell carcinoma as well. And this has a huge variety of appearances, scaly, crusty, or ulcerated. You do not normally see the pearly translucent borders like we saw with basal cell carcinoma. And this is that cutaneous horn I mentioned. That's the one where we might look and say, that's benign because it's coming away and out from the skin, but actually it's squamous cell hiding beneath that cutaneous horn. Back at the Mohs surgeon's office, had a patient with squamous cell carcinoma. I said, what am I looking at? He said, well, we're looking at some keratin pearls. That's pretty typical for squamous cell carcinoma. And this is squamous cell carcinoma leaving the epidermis and invading into the dermis. And anytime I see the word invasion, also something I don't want to hear when dealing with malignancies. A few months ago, or actually this was about a year ago now, don't judge me too harshly for taking a picture of a house down the street on fire. By this point, there were already 5 fire trucks battling the blaze. So I don't think me with my bucket of water was going to do anything to help. But what happened is the owner of the home actually was smoking in his garage and threw the cigarette in the trash can, and the trash can caught on fire and it burned down the whole front half of his house, and the smoke damage destroyed the back half of his house. So the whole house was just a total loss. And firefighters are trained to stop the spread of a fire. And they did a fantastic job. They were on site within 2 minutes. The blaze was out by 10 minutes. I mean, you couldn't have done a better job, but it spread quickly. We as eye doctors have to keep our eyes out for things like squamous cell that can spread. This patient had squamous cell 5 years ago, shows up and you see and feel something that's kind of hard, a hard bump on the upper corner of her eye. And you notice her conjunctiva is a little injected. And when you ask her to look to the left, she starts to see double. That's enough concern with the history and the diplopia in that gaze to warrant an MRI. And she was sent for an MRI, which showed a suspicious mass in the inferior lateral orbit. MRI will not diagnose pathology specifically. So the patient was sent to oculoplastics for an orbitotomy to take a sample of the tissue, and it came back as poorly differentiated squamous cell carcinoma. And the patient actually had full excenteration of the eye. Even 2 months later, after all that, the squamous cell carcinoma still wasn't done and had metastasized to the right submandibular gland. So these can be challenging cases, and a good reminder to just not give squamous cell carcinoma a second look, especially if there's something new happening in a spot where it was removed. And so
Cheers, I want to kind of echo something that you just said there.
Sure.
What's the word? Palpitation, feeling the skin. I can't tell you how many times, people coming in by just laying your hands on and massaging it, checking the other side and sending them to I use an oculoplastics and getting a biopsy, how much we can pick up, not a chalazion or something like that, just something abnormal like you're showing there. Just lay your hands on there and get it biopsied.
I absolutely agree. And I love that comment. Thank you, Greg. Yes, absolutely. Don't be afraid to use those fingers. It's one of our best tools that we have, I think, in optometry sometimes, and we forget about them. Sebaceous cell carcinoma is the third I'll mention. I don't want to spend as much time on this one, but it's worth mentioning. It is the third most common eyelid malignancy. It likes to, I think of, feed on lipids, and it likes meibomian glands. There's a lot more meibomian glands of the upper lid than there are of the lower lid, so it's more common to see sebaceous gland or sebaceous cell carcinoma of the upper lid, and it even looks a little yellowish from that lipid that's present in those meibomian glands. Our older patients between their 5th and 7th decade are the ones who have this, women more than men. And as was mentioned, more likely in the upper lid. And back to your palpation comment, that was a very timely comment, because this one, sometimes we look at this and say, oh, it's just a chalazion. But then we put our finger on it and we feel something that's rock hard and does not move when we touch it. Versus a chalazion is more rubbery, kind of moves. It's not quite as adherent to skin. If we see something that looks like this, feels like this, and keeps coming back in the same spot, we at least need to allow ourselves to think it might be sebaceous gland carcinoma. And we might see typical signs of inflammation, matarosis, poliosis, a whitening of lashes, a loss of lashes, inflammation. And this pagatoid spread is particularly frustrating with sebaceous gland carcinoma because it just spreads through the epidermis and then pops up. And like a submarine, it's down below and it pops up and produces these skip lesions. So we don't really always know where it starts and where it ends. And again, that unilateral chronic blepharitis is cause to pause and think, is that really what I'm dealing with, or could it be carcinoma? And why we don't like sebaceous cell is because it kills people. It's a potentially lethal tumor. Metastasis happens in 17 to 28% of cases, and it invades the orbit in 6 to 17% of cases. And the challenge is, as far as prognosis goes, one of the main things that worsens prognosis is how long has our patient had it. So now we've sat there calling it chronic conjunctivitis for 6 months, and we've lost precious time to get that out and get that excised. And the big baddie, of course, is malignant melanoma. This is the most lethal primary skin tumor. Why we don't like this one is because it's very metastatic. So early detection and treatment is absolutely critical. Good news is it's less than 1% of all eyelid malignancies, but I'm scared by these statistics. An American's lifetime risk is 1 in 128 of developing this, and 2/3 of all deaths from cutaneous cancer are caused by melanoma. So not one to miss. And it feels obligatory in an eyelid cancer type lecture to mention the ABCDE, but we have to remember any asymmetry, any irregular borders, inconsistent colors, or diameter being larger than the size of a pencil eraser, larger than 6 millimeters, or it's changing, evolving, or elevated, or scaly, itching, oozing, painful, we have to be a little bit suspicious of something more sinister. There's 3 main types of malignant melanoma. About 1 in 10% of melanoma cases are lentigo malignant melanoma. This is more commonly on sun-exposed skin and just enlarges radially. We often see this start with a precancer called Hutchinson's freckle, or just termed lentigo maligna. But once it's lentigo maligna melanoma, now we're dealing with cancer. The second type is the most common, 70%. This onset's about 20 to 60 years of age, an irregular border plaque, pigment might be variable and inconsistent. And where this pops up is non-exposed skin. So sometimes the upper back or anterior tibia. And I know this picture here looks a little bit like clickbait, like, oh, wow, there's no way anybody's going to ever look like that. I just was talking to our Mohs surgeon a month ago. He said he had a case of a woman who had one that looked just like this. It had been there for a long time. She didn't have money to get it taken care of. They stayed until 9 p.m. that night removing it for her. They didn't even charge her for it. Even despite all their efforts, she waited too long and she actually passed away a month after that. And that's the challenge with melanoma. You got to catch these very quick. And one that won't be seen very often for us, it's very rare in the eyelids, but nodular melanoma, very aggressive, worst prognosis. And I don't think there's any of us that would look at that and think, that looks normal. So we'll keep our eyes out for melanoma. Now let's take a look at this polling question. This one's just pictures. And these are things we've looked at so far in the lecture. So look at those pictures, A, B, C, D. And the question is, which of the following eyelid lesions is most likely malignant? So I'll give you a chance to think about that, kind of think about the characteristics of each of those pictures.
The answers just started to roll in.
Great. I know some of these, we look at pigmentation, we look at destruction of tissue, we look at location. There's a lot of variables to think about with a lot of these cases. The one I'm looking at that bothers me the most, if you haven't answered it or are trying to get a hint, is the one that looks kind of ulcerated. Looks like it's knocking out those eyelashes. Very likely knocking out.
Kind of growing downward, right?
Yes, that too. Absolutely.
Enzymes eating away.
I like that you mentioned that. That's good.
All right, let's see here. I think we've given this one a pretty good amount. I think we got people rolling in here. I'll display the results here. No one went for A, 0%.
All right.
We have B at 50%, C at 40, or just changed to 39. B went to 50, and D is now 11%. So
wow,
the winner is going to be B there at 49, but C a close second at 38.
Yeah, and it is B. That's a basal cell carcinoma. C, at first glance, it sure looks like something scary. You're thinking, what in the world? It's spread upper, lower lid. That's a good reminder of that kissing nevus. The embryology, those cells in the upper and lower lid, it's just abnormal cells in both of them. Now, is there risk of becoming malignancy? Sure, you have some risk on C, but B is already malignant. So that one takes the cake. But for those who said C, I think you're absolutely right to be concerned potentially about C, but much less concerned about what B already looks like. So good. Thank you for the answers.
Is D kind of pyogenic? You know, it's that misnomer that kind of looks like a pyogenic.
You got it. Pyogenic granuloma. That's right. That's right. And then A looks like a seborrheic keratosis. Good. Let's keep marching. We've done a lot of eyelid, and we're going to get into conjunctiva. Some of these we'll see as similar to what we saw with the eyelid, but I want to go over a few entities of the conjunctiva. First is a conjunctival cyst. And I think its pathophysiology is going to be most similar to our epidermal inclusion cyst, where in the conjunctiva, we remember that there's epithelial cells, and beneath that are the substantia propria, the stromal cells. And epithelial cells, through trauma or something else, can get pushed down deeper into the stroma. And they're still epithelial cells. They do what they think they're supposed to do, which is proliferate, and they create this area, this ball of fluid, basically, which is normally clear, but could it even be turbid? I would suspect they become turbid or yellowish because of goblet cell mucus secretions into that area. Most don't cause a problem, but this one struck me as being really quite dramatic and large. A 62-year-old with cloudy vision in the morning. She says, I got to pull down my lower lid just to clear up my vision. And if you haven't tried slow-mo on your phone when you're doing a slit lamp, I highly recommend it. It's great to see the way that the lids come down, and you can actually see that this is impeding the full closure of the eyelids, upper and lower, never come into contact with one another. So she was excited to get that one removed. Now, some suspect or look at this and say, well, that looks inflammatory in nature. That may be true for some of these, but just a quick reminder, most of these inclusion cysts are not inflammatory in nature, therefore will not respond to steroid. And this is before and then 2 weeks after steroid. Didn't seem to help. Was that a comment from? No. So most of these need to be surgically excised, can be removed with simple excision. Oftentimes we think, oh, can't you just penetrate a needle into that and drain it? But if the whole fluid cavity is still in place, then that fluid is going to continue proliferating and fill that cyst back up. So these need to be removed in totality in most cases, or cauterized from the inside out, and I'll show that in a moment also. Conjunctival chalasis is a particularly aggravating conjunctival finding for some patients, leads to ocular surface problems. This is just very redundant, loose, normally non-edematous conjunctiva. But if you take your finger and lower the lower lid and manipulate that conjunctiva, you see it just peeking up at you. And every time they blink, they feel it, and it can be very irritating to the patient. With conjunctival chalasis, it can even cause an issue where if you have a small flap of conjunctival tissue, which may be very hard to see in this video, but a little flap of conjunctival tissue can block the puncta. So patients come with symptoms of irritation and also epiphora. Their eyes are tearing too much, and it's because the conjunctiva is blocking the puncta. So these cases warrant a removal of conjunctiva, or in most cases, cauterization of the conjunctiva. This is one technique for cauterization. In this case, the surgeon is using forceps to grasp a large area of the conjunctiva and then applying heat to that little tissue that's poking up out of there. And that's one way to do it. That works fairly well. Shrink wraps that tissue. I remember in college, I worked at a barnwood picture frame shop. And at the end of building a barnwood picture frame, we wrapped it in the plastic wrap, and I took a hot gun and heated that plastic wrap and just watched it shrink down and contract. And that's what the heat's doing to the conjunctiva.
Hey, Pierce, on that back picture, was that the inferior fornix that's superior?
That one's inferior fornix there. I think we're in surgeon's view flipped there.
Yeah, so the head is towards the bottom. Okay, I just wanted to make sure. So they're fixing that inferior. Okay, perfect. Thanks.
Yes. Yeah, thank you for the clarification. One more, this is slit lamp view. So top is top and bottom's bottom in this picture. Just an example of what the conjunctival chalasis looks like here. Again, you press your finger and you just see it barely prolapse and peek up behind at you there. And this particular patient had one more little bonus. When you flip down their lower lid, they actually also had a little conjunctival cyst right there. And what was done for this patient was first a lidocaine injection for numbing of the conjunctiva. Since the surgeon had a needle in their hand already, they used that to penetrate into the actual conjunctival cyst and try to drain some of the fluid and expand the opening. That can be effective sometimes, but what you'll see, it'll just go real quick here, is an actual cautery unit inside of that conjunctival cyst cavity. And that's going to be right there. where you see that little cautery is applied, and that's going to try to shut down that conjunctival cyst. This is the actual conjunctival cautery. This one's not done with jeweler's forceps. This is just like a spot welding, different parts of that conjunctiva to just contract it down. And you can see it, you can hear it. The only part you don't get in this kind of a webinar is you can't smell it. And that's the part that just, it lingers with you for a long time, that smell of burned flesh. And it's very successful for patients. This is very aggravating having conjunctival chalasis, and you can see it continues. In this case, was just the inferior conjunctiva. This patient also previously had the superior conjunctiva treated, but they needed a little bit more treatment. And 1 week later, conjunctiva looks nice and tight and smooth, and they're feeling a lot better. A few very small petechial hemorrhages that are still resolving, but that conjunctiva is nice and firm for that patient. So good, successful treatment.
What do you prefer if you were going to send that for your patient? Do you just like kind of that spot weld treatment? What do you like to do? What do you like to refer for?
Yeah, spot weld, but that's probably because that's just the one I'm more comfortable with the surgeons that I work with here at our eye institute. So I don't know if there would be pros and cons one versus the other. Both seem to have similar long-term success rates. So I would say the spot weld would be just agreeable for anybody. Yeah.
Perfect. Thanks.
Yeah, thanks, Greg. One other area that produces clear fluid under the conjunctiva worth mentioning is our lymphatic system. If you were to take your fingers and hold on the inside corner of your eyes and drag down your cheek down to your submandibular lymph node, that's where some of our lymph drains. The lateral side drains to our preauricular and parotid lymph nodes. So that's the drainage of lymphatics, and sometimes that drainage gets backed up. In those cases, we call it lymphangiectasia, where we see these weird dilated sausage-shaped channels. Because of the fine vascularity in the conjunctiva and the episclera all anastomosing in that area, we sometimes see blood actually leaking into those clear channels, and it looks like a blood-filled channel, but most of the time it's just clear. Even anterior segment OCT, I feel sad I don't use this as often as I should, but anterior segment OCT can be used very nicely to look at lymphangiectasia, and you can see those pockets of fluid just beneath the conjunctiva. And in this case, the report was talking how it's elevated and has a thickened appearance to it from the edema. And that's what we might see on anterior segment OCT with lymphangiectasia. I had a student, they were working with a classmate, and she said, "Hey, Dr. Kenworthy, come take a look. What's that on my classmate's eye?" And I looked for a second, and I thought, oh, I think that's a lymphangiectasia. It looks like it's just dancing every time they blink. And that's a really small example of lymphangiectasia in that particular patient. Lymphangiectasia, if it becomes a cosmetic problem or irritating to the patient, can be treated a variety of ways. One popular way is with that radiofrequency unit, the Elman unit that we have at our clinic, for example. This is a 24-year-old female. Her left eye has been bugging her a little bit for about a week, not too bad. And her boyfriend does, I guess, what boyfriends do. And he got very close to his girlfriend. And then when he got so close, he looked at her eye and said, "Whoa, what's that on your eye? Is that a worm? What's on your eye?" And sure enough, it was lymphangiectasia. So she had one treatment with the radiofrequency unit, just like touching the surface of the conjunctiva to try to close and contract it down. Needed a touch-up appearance. That's why you're seeing that outline of where the hemorrhage is from the touch-up treatment. And finally, she looked back to normal, and the boyfriend could get close to her once again. But there it is, initial lymphangiectasia and final result. So pretty good success on the radiofrequency.
Hey, Chris, before you get too far away from conjunctival chalasis,
Sure.
have you ever heard of prescribing Timoptic to treat it? That was one of our questions that came in.
I haven't. Have either of you? That's
I've not.
Greg?
I have not, but if the person would like to make some more comments, we can definitely put it out there. I've heard of Timoptic for migraines, but not or Timolol for migraines, but not for the conjunctival chalasis. So
yeah, that'd be cool if it works. I haven't heard of it though. Interesting. Thanks for sharing.
But while you're lecturing, I have the ability to Google, so I will Google for you.
Get an answer for us. I'll mention while you're looking that up too, radio frequency. This is an interesting application of radio frequency. That same Elman unit can have a very fine tipped point that can be actually placed inside of a puncta. And this is another form of permanent punctal closure. So as opposed to a cautery unit that burns just the opening at the surface, this is closing from the inside out. And that's a pretty common way now where we're having our patient's puncta closed permanently, is with radio frequency. And just like we saw with the eyelid, we can also see the conjunctiva develop capillary hemangiomas. And capillary hemangiomas look similar on the conj as they did on the skin, a very bright red protuberant type of a lesion. Most of the time, this is in the absence of any trauma. It just pops up, bad luck, and we get this proliferation of these capillaries on the surface of the conjunctiva. A while back, we were doing these fun sports screenings, had about 20 athletes who were hopefuls to go on the Arizona Diamondbacks team. And they were coming to our university for a sports vision screening. And one of them said, "Hey, why is my eye red?" And I looked at it, I said, "Oh, I think I know why. You have a capillary hemangioma." And it was so fun watching as he blinks, that ball of blood just drains out and then refills after each blink. Actually, one of those 20 athletes, it wasn't this one, sorry, but one of those went on to play in the World Series. So I guess our vision screening is very successful here at Midwestern. Interesting, we brought up beta blocker timolol for this type of hemangioma. This is an interesting case report of a patient who had glaucoma, had a capillary hemangioma, was treated with timolol dorzolamide, and it actually showed a reduction in her capillary hemangioma. So we see that beta blocker to the rescue again for capillary hemangiomas. And one more case report, this was 0.5% gel of timolol for 4 weeks, and you see the before and after of the resolution of that capillary hemangioma. I'll talk about conjunctival lymphoma. This one is the one that I feel like I at least need to allow myself to remember that this exists and can show up in our patients, and to let myself think, if I think it's just chronic conjunctivitis or episcleritis and it's not resolving to normal treatments, it might be lymphoma. Lymphoma is conjunctival lymphoid tumor. It's salmon pink coloration, just starts real slowly, normally doesn't have very many symptoms. It's not tender, not ulcerated. It doesn't seem to have any feeder vessels. It's somewhat mobile on the globe. Most of our patients are 50 years or older, but some it's documented as young as 12 years old with conjunctival lymphoma. And what bothers me is that most of the textbook pictures look nice, salmon pink. You look at that, you say, yeah, I'd be concerned about any of those. Might look a little like a follicular conjunctivitis, this picture on the right here. These pictures, I don't think I'd be happy with any of these walking into my clinic thinking, that's just normal conjunctivitis. That looks like something much more problematic. But again, that salmon patch coloration to the surface. If lymphoma is detected and diagnosed, it needs to be treated with external beam radiation. That is the gold standard treatment. This is a case report of somebody with 20 sessions of radiation that finally resolved their problem, their tumor. And on the top, just contrasting, that again is what a textbook would show, a real large salmon pink mass, maybe something real juicy in the inferior fornix. And the picture at the bottom is a patient that actually walked into our clinic. And I looked at that picture and that patient and I thought, boy, I think I probably could have called that episcleritis or scleritis at first glance. And maybe I'm allowed to do that. Maybe I can call it that initially and prescribe pred, acetate, or some other steroid, but at least I need to allow myself within a week or two, if it's not getting better, to think it might be lymphoma. So we're going to talk about a few other conjunctival lesions. This is a segue into that. I want to show these 3 pictures. Which of the following would be most helpful at diagnosing these upcoming conjunctival growths? A, using vital dyes like glycerin green, fluorescein. Would B, biopsy. C, anterior segment OCT. Or D, get a better slit lamp. That'll help me.
The polling question is open. My quick search, I did not find anything on timolol for that, but not to say it doesn't exist. It was a quick search. It got ended quickly because I had to launch the poll.
Yeah. That's a good question to think about, though. If there's other medications that can help with some of these otherwise benign things that we sometimes say, oh, they need surgery, but could some medical treatments be available? That'd be cool.
I was trying to think of the pathophysiology behind that. I mean, with conjunctival chalasis, it's kind of a tummy tuck is what you're doing. So you're trying to constrict the tissue, and that's why you're doing, heat therapy. You can do thermal therapy, whatever you're doing to try to do that tummy tuck. I'm just trying to think of the beta blocker pathophysiology of tightening that tissue up. So
yeah, it's not
maybe the
coming to me
BAK in it, maybe the BAK causing the inflammation and causing it to tighten up.
Yeah. So vital dyes, biopsy, anterior segment OCT, or a slit lamp is going to help us diagnose these lesions, which none of us have seen yet. We're going to look at these in a moment, but
Here we go. We've got 5% with using vital dyes. We've got 57% doing, 56% now doing biopsy, with 36% doing anterior segment OCT, and 3% saying get a better slit lamp.
and I suppose it's an unfair question because yes, anterior segment OCT, as we mentioned, can help with some of these, but any multiple choice, the most helpful. We look at these, we don't know what the diagnosis is from OCT or slit lamp, but we do know what it is when we recommend for biopsy. And I think it's important to remember as we look at the next conjunctival lesions, there is a lot of overlap in appearances. They look very similar one to the other, and biopsies are needed past this point. And I'll keep marching past this point, but I don't want to deprive Joe or Greg if they had a comment there on that last poll.
I have
No.
no comment. Nope,
Okay.
you're good.
Great.
And we're
Biopsies
caught
need-
up in the questions.
Okay, good. So epithelial tumors of the conjunctiva, these are going to be, we'll start with conjunctival papilloma. And again, this may look like the other things we'll look at here. This is a benign squamous cell tumor that can pop up at any age. And our good old friend human papillomavirus can cause these to form. You might see something huge like we see in this example, very quick proliferation, making it even impossible for the patient to close their eyes all the way. Or these fine little vascular fronds just projecting off the surface. And there's a wide variety. They can be small down in the fornix, can be a part of the plicae semilunaris, the caruncle. A pedunculated one has a stalk on it. Sessile is more smushed down and flat. But I would imagine even a sessile papilloma, if you wanted to, you could take your jeweler's forceps and grab the edge of it and pull that up away a little bit and find a stalk down beneath it. I kind of think it's sort of like a mushroom that's just been stepped on in the forest, just smashed down and sessile there. Here's an example of a 39-year-old referred in for this red spot. It's been there for more than 5 years, not bothering him. He's not even worried about it. The surgeon's not worried about it, but he said, you know, I think it's time to get it removed. And this came back as squamous papilloma. It does have some concerning potential characteristics to it, but again, with no growth, been there for a while, not bugging the patient. We weren't really concerned about malignancy, but biopsy definitely confirmed that for us. Now we get into a more concerning territory. It's our ocular surface squamous neoplasia, OSSN. This is a very wide spectrum of malignancy, from just mild dysplastic changes all the way to invasive carcinoma. And the non-invasive conjunctival intraepithelial neoplasia is going to be above the conjunctival basement membrane. If this OSSN penetrates through conjunctival basement membrane, now we're dealing with an invasive squamous cell carcinoma. So back to our slit lamps, for example, I know we love our 40x magnification. We go to those trade shows and find the best slit lamp, but even the best slit lamp is never going to diagnose this properly for us. They need a biopsy. So what I'd like to do is look at a few examples. First, set the stage for conjunctival intraepithelial neoplasia. Goes by some other names, carcinoma in situ or disc keratosis. And about 95% of these are present at the limbus. And that's a good reminder that this is very commonly associated with UV exposure. And again, human papillomavirus. Also patients with xeroderma pigmentosum, where the body doesn't repair itself quite as well after UV damage. These patients can be predisposed to CIN. It can really pop up on any part of the conjunctiva or the cornea, but most commonly interpalpebral, where the sun is exposing that conjunctiva. And again, a wide variety, from the gelatinous limbal thickening, the leukoplakia, these white clumps on the surface that we see, down at the bottom, these vascular fronds, that papillary appearance, more associated with human papillomavirus, a very wide range of presentations. This was one I was very excited to see. It was my first one I saw when I was out of school about 10 years ago, 45 years old. I had just seen him 4 months before. His eye looked white and quiet, normal, and he came back and said, look, my eye's red now, and it's been getting worse for the last few months. And sure enough, you put the fluorescein on and see it just filling all those little craters of that lesion right there. And on close examination, you see a pretty characteristic hairpin configuration of that vascular pattern consistent with OSSN. Now I'll show some more examples, but first set the stage with some treatments. Back then, it seemed to be most customary to say this patient just needs surgery, remove that lesion, and that's still done very commonly for any OSSN. But there's a little shift where sometimes we're seeing just chemotherapeutic agents being used as primary monotherapy to see if that patient can have the OSSN resolved, with drops before doing any surgery or in combination with surgery. Those three drugs are 5-fluorouracil, interferon alpha-2b, and mitomycin C, each with their own mechanisms of action and each very effective against OSSN. The only problem is interferon alpha-2b was discontinued a little while back by the manufacturer, so it's becoming a little harder to get that one in the United States. You can look international and find that some places, but more commonly for OSSN, 5-fluorouracil is going to be the go-to medication for many of these. So showing a variety of examples, here's OSSN number 1. And at first glance, you look at this picture and say, well, maybe that's just a pinguecula. Is that a little early pterygium perhaps? And you pause, and then you see these weird vascular fronds crossing over onto the cornea from the conjunctiva. Pinguecula is up here a little further. It's definitely in a sun-exposed area, but this now is more concerning for OSSN. And that was OSSN and was treated with 5-fluorouracil. Example 2, a 77-year-old with this growth that started 2 months ago. And what I like about this is the very prominent feeder vessel, a really large caliber feeder vessel feeding this OSSN. And this one, the biopsy report came back as squamous dysplasia, or in other words, non-invasive OSSN. And they actually had an injection of 5-fluorouracil, had the biopsy, and had the medication injected to help control this. And what I like looking at this is before and after. Before, there was a big feeder vessel. It was feeding that OSSN. Afterwards, that vessel had nothing to feed anymore. So it said, well, I guess I'll go back to a more normal size, and it shrunk back down to a normal caliber. And that's what we might see in these cases. Example number 3, this patient has been through a long journey, and I'm going to edit some of his to compress it a little bit. But long story short, 8 years ago, had some issues starting with his eye. Malignancy was always negative, never had malignancy, scrapings were normal. And then you look at him today and you see this odd petechial kind of vascular frond pattern on the surface of his conjunctiva. You look closer at it and that feels wrong. Something just feels wrong about that. That's not what any typical pterygium or any other typical conjunctival lesion should look like. He was treated with 5-fluorouracil. And I'll mention when I say a cycle of 5-fluorouracil, a cycle is 1 month. 5-fluorouracil is treated as 4 drops a day for 1 week. But because it's so toxic and irritating to the ocular surface, the patient then has to take 3 weeks off of that drop. So I can imagine some of you have had a terrible week of work, so bad that you had to take a 3-week vacation after that. That's what it's like with 5-fluorouracil. And after 2 cycles, things are looking pretty encouraging. That 5-fluorouracil is working well. 3 cycles go by. It's not totally gone. 4 cycles go by. You're thinking, why is this not all the way gone yet? 6 cycles go by. You're still seeing proliferation of vasculature. It's not feeling right. Long story short, patient had some 5-fluorouracil injected, also had surgery scheduled to excise that completely. And this area looks like a recurrence of OSSN where we see that vascular pattern, those little fronds projecting out, indicative of OSSN. And finally, I'll fast forward to earlier this year, saw the patient and they were looking much better. Nice and clear conjunctiva. The OSSN is gone, and we hope it stays that way. OSSN number 4, another fairly classic example. I think most of us would look at this and say, that is not normal. Send that out, get that removed. That was OSSN treated with 5-fluorouracil. And I like this example very much. Example number 5, this started about 6 weeks ago. They're having foreign body sensation and discomfort when they blink really hard. And what I like about this is that lissamine green is very effective at staining dysplastic cells on the surface of the conjunctiva. And we see it doing that very nicely over the conjunctiva. But not only that, it appears like those cells, those dysplastic cells, are marching their way onto the cornea. And we're seeing lissamine green stain that. And I think it's a good take-home point that the cornea itself is avascular. The cornea is not just going to wake up one morning and decide that it wants to have a vascularized tumor growing on it. It relies on conjunctival abnormalities to then proliferate and spread onto the cornea. And that would be indicative of an OSSN. And that came back as squamous cell carcinoma in situ. We're still talking OSSN, but now we've penetrated through the basement membrane with invasive squamous cell carcinoma. And this penetrates the basement membrane. I don't think any of us would look at those images and think it just looks like chronic conjunctivitis, but early stages may just look like chronic conjunctivitis. And we see feeder vessels, these papillomatous lesions might get all the way over on the cornea. Good news with this squamous carcinoma is that we don't normally see metastasis and we don't really see a lot of intraocular extension. It's pretty happy to stay in the conjunctiva. And if a surgeon is actually really concerned about deep tissue invasion, that penetration through the basement membrane, I think this has to be one of the coolest sentences I've ever read in a textbook. The author must have been Mr. Freeze, because he wrote, a cutaneous cryogun may be used to produce a full thickness transscleral ice ball. And this is him in action.
We use the underside technique, where we freeze large portion of the conjunctival margin using double freeze thaw technique.
I know what you're thinking, Mr. Freeze lost his accent, but actually that was world-renowned Dr. Carol Shields, that was her voice, and she is an expert on ocular oncology. So that was actually her voice showing how to do that freeze-thaw technique. And we're in the invasive. Here's examples of this. This was a bump on the right eye, feels like. Vision's blurry when he wakes up, has mild redness in the right eye. And good thing Visine to the rescue, making it feel a little better. But we know that's not going to respond properly to Visine. That needs to be removed, and that came back as actually squamous cell carcinoma, moderately differentiated squamous cell carcinoma in that particular case. And you see the lissamine green staining the surface. You see it's really extended over onto the cornea, and it's affecting substantial amounts of tissue. And another one who was just working under his motorhome, and he says, I had this foreign body sensation in my right eye. It started about 2 months ago. Maybe I got some dust in my eye. And he tried some antibiotics, thought it maybe helped a little bit. It keeps getting bigger, and his last doctor called it a pterygium. And before I pass judgment, it's possible when the last doctor saw him, it looked much more like a pterygium, but I think most of us would look at that and say, that's something more than just a pterygium. And sure enough, that was invasive squamous cell carcinoma. And the surgeon did a fantastic job, and the margins were completely free of tumor. So that was a great result for that surgery.
Hey,
Now,
hey, Pierce, well, I want to make a comment here because,
please.
we see a lot of these things in our area. I had a gentleman come in and, he had this huge nodule on his eye from Lyme disease. And it was huge, and it took a year to go away.
Oh, wow.
We see flectenules, we see inflamed pinguiculas, we see, these lesions. And I think, the key here is, they're kind of hard to tell sometimes when they're early. But you put them on steroids and they don't respond, or they don't respond like you think they should. That's when I think you kind of have to have that low threshold of that biopsy that you talk about. I think a course of, a month even, to see if these things will reverse, because they could be chronic inflammation. But, if they're just not responding the way they should, get them off for a biopsy.
Yeah, I think that's a great tip. And the steroid is a good little test, but if it's not doing the job, you think about something else and get it out for a biopsy. Great comment. Thank you, Greg.
Yeah.
Well, we're going to round this out. We're getting towards the final home stretch here, but we really have to talk about these pigmented conjunctival lesions. And these are our conjunctival nevus, secondary acquired melanosis, primary acquired melanosis, and then the big baddie that we sadly have to finish on is melanoma. And if you're like me, I sometimes look at pigmented lesions of the skin or of the conjunctiva and I psych myself out. Maybe it looks really bad to me, but it's not bad at all. Or maybe the opposite. I don't think it's that bad, but it's actually a terrible thing on the conjunctiva. And again, it goes back to, like Greg mentioned, with those thresholds of needing to send out for biopsy. Think about, what are the characteristics? What's the history here? How concerned am I that this either is some type of a melanoma or carcinoma, or could become that? So we need to have a reasonable amount of concern. The first is a conjunctival nevus. This is the most common melanocytic conjunctival tumor, about 1% chance of malignant transformation. That's important because there is a chance of malignant transformation even from a conjunctival nevus. And these pop up in the first to second decade, and these have a characteristic slight elevation to them. As opposed to melanosis, it's very flat. These ones are a little bit elevated. And what can concern us sometimes is that these nevi become a little pink and congested in kids and young adults. Oftentimes, that's just from puberty, from hydration changes at the surface of the ocular surface that leads to inflammation. And we see this extra vascularity, like I saw in this 14-year-old patient. Looked like a nevus, but there was these little fine vasculature around the area there. It's cause for concern, but maybe not too much concern if we can blame puberty or something else, or have monitored this patient for a while. And a lot of these patients get sent out for excisional biopsies that maybe didn't need it because it was benign. But certainly if you're concerned, send it out. Conjunctival nevi could be very heavily pigmented or lightly pigmented, small or huge. So there's a wide variety of what nevi look like. And their locations most commonly are the bulbar conjunctiva at the limbus, second most common at the caruncle, and the least common is the plicae semilunaris. So we get a little more concerned as we get into the anatomical areas where these are less common. And sometimes they even have cystic lesions inside of them. And sometimes they even have some vascularity. And sometimes a nevus even is not pigmented, and it's a non-pigmented nevus. So these can be very frustrating to look at and can cause a lot of concern, which is why I think photo documentation can be very helpful for a lot of these patients. This was a patient who had a conjunctival pigmentation for many years, got sent into our anterior segment clinic at the university. I think it's a valid concern because you see a pigmentation that popped up a few years ago and looks like it has a feeder vessel. Good thing for the patient is that it was a compound melanocytic nevus, so no cause for serious concern there, and it's gone and can never pose a problem for the patient. We get into the melanosis. Melanosis is excessive melanin production or retention of pigment by those melanocytes throughout the conjunctival surface. These are flat and do not elevate the surface like our nevi were doing. And we can separate these into either secondary acquired melanosis or primary acquired melanosis. First, a schematic and a reminder. Any mucosal tissue, including the conjunctiva, has, generally speaking, a set number of melanocytes, these superficial dendritic melanocytes. They're producing melanin. If they do a really good job producing melanin, then the surface looks darker. If they don't do a very good job producing melanin, then the surface doesn't look as dark. When we have something like secondary acquired melanosis, or sometimes referred to as complexion-associated melanosis, this is secondary normally to genetics. These patients have darker pigmentation of the skin, have genetic factors for more pigmentation, and we see it much more commonly in the conjunctival surface. Good news, this does not predispose the patient to malignant melanoma at all. And we normally just see this get a little darker over time in both eyes, and we don't get worried about it. Where we do get a little more concerned is primary acquired melanosis, PAM, and this deserves just a little more of our attention. It looks just like secondary, just like our patients with darker pigmentation, but the history is going to guide us a little differently. These are normally fair-skinned Caucasian patients, normally just one eye, new onset of a pigmented lesion, and this is most commonly after the age of 45. And these are very flat pigmented, kind of golden brown, dark chocolate pigmented lesions. And that is a primary acquired melanosis, new in our white patients of older age. They can show up anywhere on the conjunctiva, even the palpebral conjunctiva, so we need to avert the eyelids. And if there's a sudden onset of nodules or other concerning characteristics, we get worried about melanoma. Now back to our schematic, just proliferation alone of melanocytes is not a huge concern. That's what primary acquired melanosis is more melanocytes now. But if you just have proliferation and they're all perfectly normal, we could call that PAM without atypia. There's no malignancy there. It's just more melanocytes and more pigment. Where we get concerned is when we see more melanocytes and they're weird. They are pleomorphic, their size, their shape is different. And this, of course, is seen pathologically, not seen at the slit lamp, which is more reason for sending these out for referral for biopsy. That's what we would call PAM with atypia, and there's a 50% chance of malignancy within 5 years. So how do you know if it's with or without atypia? You need a biopsy. So Pam says, it's not my fault you thought I was normal, that's on you. So keep that in mind. 30-year-old Italian female referred for pigmentation in the left eye temporally. It's been there for about 8 years, but recently in the last few months, it's been getting a little larger and a little darker. So she had it excised, and the good news is it came back as just benign melanosis with dendritic melanocytic hyperplasia, basically saying PAM without atypia. Glad we got it out there. It can never be a problem, but it wasn't a problem, and now it's gone, and we know what it was. This patient just came in recently, a few months ago, 80 years old, with a very rapid onset of a nasal conjunctival lesion just on that inside corner that you see. Not sure if that's going to buffer properly or not, but I think you should see that right at the inside corner. It's even affecting the plicae semilunaris, some of the caruncle. You can see it best when patients are looking far out to the side. This is just a short surgical video of the removal, the excisional biopsy for this. They removed the entire pigmented lesion, that whole area of conjunctiva. I won't show the whole thing, but they started off with those ink blots to create themselves a little dot to dot kind of a cutting line. And they ended up extracting that out completely and sent it off for biopsy. And the concern is real when you see a new pigmented lesion to go to these measures and remove that, because that very well could become melanoma or may already be melanoma. We're not sure until the biopsy comes back. And this one was primary acquired melanosis without cytologic atypia. But the pathologist, I like that they added this at the bottom. Clinical surveillance is recommended with rebiopsy for any signs of thickening or growth. So we still watch these patients closely. This is after they had the conjunctival stitches removed. All the pigmented lesion was gone. They're still fine after these months, but we keep an eye on these patients. Now, I'm going to go into this polling question. It's a photo type diagnosis about malignancy. Which of these is at greatest risk of becoming malignant? So in A, we have a 20-year-old Korean female, had that since birth. B is a 70-year-old Caucasian male, noticed that about 3 years ago in one eye. C is a 75-year-old African-American male. It's been getting darker for the last 20 years, and it's in both eyes. And D is a 45-year-old Mexican male and had that since birth. So take a look, think about which one are you the most concerned about based on its appearance and history as well.
And Pierce, while you're doing that, I want to make a comment going back to kind of your skin talk, which was fantastic. And I know we're kind of doing some conjunctival stuff here now, but a lot of optometrists are doing IPL. And IPL, you know, targets red, so rosacea and hemangiomas. And then the brown, which is going after, you know, maybe litigines. You know, I know IPL could be used for dry eye, but some are moving into some aesthetics. So I think this course is fantastic for anyone that's doing IPL and looking at lesions, making sure they're not trying to remove an age spot or removing litigines when it could be something more serious that's out there. So, you know, I think this course is fantastic and a great review as we are treating rosacea, hemangiomas, and pigmentations with IPL, making sure that we're not trying to treat something that could be a little bit more serious, cancerous, maybe needing a biopsy that's out there. So thank you for doing this.
Oh, absolutely. Great comment. And yeah, I'm seeing all over a lot of IPLs popping up. We've got one that we use here all the time, more so for the rosacea, like you mentioned, MGD. But yeah, people are getting into cosmetics, aesthetics, those things all over the place. So it's an interesting new option.
Well, I think the audience did well here. We have 2% with A, 98% with B, and
Good.
no one went for the other C or D.
All right, they're on it. Great group. Yes. And the concern there, of course, with B is, well, and then I guess it's not quite a fair question because we don't know until we get pathology, is there atypia or not? But definitely we're concerned if there's atypia with that PAM. So history, everything leads us to much more concern for B. Thank you.
And how about the unilateral presentation too?
Oh, yes, absolutely. Unilateral, new onset Caucasian patient. Now I'm going to try to be respectful of time and I'm going to just get through melanoma in our last, I'm going to try to do this in about just 2 minutes here because I want us to end on time. Now you see a patient, 65-year-old Mexican male, pigmented lesion for 6 months, changing color and growing. It's too late for risk. This is malignant melanoma. The reason I spent so much time on PAM is because melanoma we don't want. 74% of melanoma cases come from PAM with atypia, 7% from an existing nevus. So all of these cases here, we can blame PAM for these melanoma cases time after time after time again. So catch PAM, catch it early to stop it from becoming these bad lesions we see here. Sometimes melanoma is even amelanotic, doesn't have as much pigmentation, and we get very concerned. So let's remember the most important predisposing factor for conjunctival melanoma is presence of long-standing nevus or PAM. So we worry about weird location, feeder vessels, growth, or adult age. And the big concern here really is that accentuation doesn't even improve survival rate, mortality, and I hate that word because it means we're dying. Mortality at 5 years is 12%, at 10 years is 25%. And it's like giving the patient, the melanoma, a passport to spread throughout the body. So what do we want? No metastasis, which is why this is a very scary image of this lecture. This is a melanoma cell invading a lymphatic vessel and spreading. And patients like this have a very bad life plan when they just wait and wait, finally get it removed, and they have melanoma. For the sake of time, I think I might call it there. I just had one more case, but I'm going to go to my final slide here, if that's okay, and see if there's any other comments from Joe or Greg.
No, no comments from me. I looked at the chat room just a moment ago, and I think we are good on that.
Great.
Yes, you're all caught up.
Well, thanks, Joe. Thanks, Greg. It's been great to join, and I've really appreciated the time with you all.